have nothing to disclose, and this article was recently published in Journal of Personalized Medicine, which has an impact factor of 3.5. In the article, we proposed diagnostic criteria and classification. So, in the outline of the talk, I'll talk about what was the purpose of study, material methods, results, and conclusion. So, as we know that equilibrium is ability of an individual to maintain posture as well as spatial orientation at rest and during movement also. When we are moving actively or passively, it helps, the equilibrium helps us to maintain posture. So we know that there are three mechanisms which help, like vision, proprioception, and vestibular system. And the integration of all these things happen in the uh, cerebellum. And the cortex has conscious control over all this. The cerebrum and other centers have a control over these centers. Now, at rest, we can see like when we are lying down, when we are sitting or standing at one place, the balance control is still functioning even in a lying down position. It works as a pacemaker activity to help us to maintain proper uh, posture and proper balance, like to maintain the normalcy, that we don't feel any dizziness or don't feel any abnormal sensations. During active movement, when we are walking, this system again helps us to let us know the speed of walking and various aspects of our movement. And when we are in the passive movement, like passively we are sitting in a vehicle, that time also our utricle is these otoliths, they help us to know the what is our speed in the linear acceleration, what is our speed, like, and various head movements we are doing while in sitting in the vehicle. The vestibular system is constantly active and it helps to give inputs to the other systems, and all these inputs are integrated to help us to do that particular function without any disorientation. So as we know that when we drive, driving is a dynamic environment because of modern highways. It provides a complex environment, and it's a learned cognitive skill, like it is a learned skill. It is not, we have to go through a proper process of learning driving, similar to all the skills like cycling or this. It's a special skill, and it needs spatial cognitive ability. Apart from spatial cognitive ability, it needs a lot of many cognitive functions, which I'm going to elaborate. And if we, because of this article, I went into details like what are the different areas of neuraxis we need while driving. It requires a lot of most of the parts of brain. So in terms of higher cognitive function, we need visuospatial orientation. Like when we start a journey, we should know where are we going. Like basically, we have a map inside our brain, or at least we start the navigation. So we should know that navigation function, like how we are going to go. And subconsciously, initially we do it consciously, the where we are going, and as we know the route, and it happens subconsciously because our visuospatial areas, the maps are stored. And memory is very important, the memory of various areas, where roads, signals. Then comes the visual cortex is important because the coordination of optic flow while driving, the information coming from the right half of the visual field and the left half of visual field while moving is called as optic flow. So why it is called optic flow is it is a continuous flow of information coming to the occipital cortex, and it is a moving stimulus. For example, in case of semicircular canals, when we move our head, the fluid moves and gives the movement, the this information about head movements with respect to body and the gravity. Similarly, the visual cortex interprets the optic flow coming from the right half of the visual field and the left half of visual field. And vestibular cortex plays a very important role in spatial navigation, It helps in the judging the speed of the car, and auditory stimuli also, like vestibulocochlear, you can say. We can, while driving, the auditory stimuli which are coming also help us. In terms of cranial nerves, the second cranial nerve is important for vision. Third, fourth, sixth cranial nerve is important for extraocular eye movement. Eighth cranial nerve, as I discussed, it is important for like vestibular sensations and auditory sensations. And the 11th nerve is important for the neck movements. The spinal accessory supplies the sternocleidomastoid and trapezius for the neck movement. Motor system is needed while driving, that is in terms of pyramidal and extrapyramidal control of upper limbs, trunk and lower limbs. And all the four limbs are needed while driving, like all four limbs function. I'm really sorry, I kept my camera up. I'm sorry, now I think it will be proper. Yeah. So what happens is, the motor system is needed for coordination of all the four limbs, because while driving it is a coordination between all the four limbs, like two hands holding the steering wheel, and both the legs are needed, accelerator, brake and clutch. But if it is an automatic vehicle, if it is left hand driving, then left leg is at rest, and if it is right-sided driving in an automatic vehicle, right leg is at rest. So it depends on like what type of, it remains the left-sided leg remains at rest in both automatic vehicles, in both sided drivings, by the way. Then comes the sensory system, like proprioception, touch, and vibration. Like I why I came to know about this thing, like how I came to know about proprioception, touch, vibration is needed. I had a patient with diabetic neuropathy, and he had large fiber neuropathy, and he lost his sensations, proprioceptive sensations in the feet. There was vibratory loss, there was loss of touch sensation and proprioception. And he was a school driver, and he was about to lose his jobs because he was giving undue pressure on the, he was not able to judge how much like brake to apply in certain situations, like while stopping the car he was suddenly braking. So that was like that happened because of lack of proprioception and touch. So normally when we drive, we keep our leg on the accelerator mildly, and we know how much to accelerate depending on the situation. So because of lack of that fine touch sensation, proprioception, he was not able to judge how to use it properly, so that can sometimes be a problem. And even I encountered a patient of foot drop patients also not able to use because of lack of motor activity. So it is not only the higher cortical and cranial nerves, it is motor system, sensory system, and the most important thing is the cerebellum, like which coordinates all the centers like vision, proprioception, and the vestibular inputs, and it helps in the like properly judging the like how much fine tuning of activity, motor activity is needed. It helps. So vestibular system, as we discussed, it plays a vital role in spatial navigation and orientation, and it decide there is activation of vestibulo-ocular reflex during few movements, and there is a suppression. So while driving, we need to move our head to look at the shoulder, look at the blind spot, look at the central mirror. So a lot of things are happening unconsciously, like while driving. So many systems are into the work for proper driving environment. So visual system, so as I discussed, there is a differential movement of the visual field in the right half and left half. There is a paucity of nearby visual cues while driving, because we have to keep constantly looking at the road, and there is a paucity of nearby clues. Visual dependency to decide the distance, like there is so much visual dependency while driving to decide the distance. So it's not only the vestibular system which plays important role there, but it is a visually dependent environment of driving. And as I told, because the stimulus is moving, the environment in which we are, it is moving, it is called optic flow. And the right and left half of the optic flow, if it is asymmetric, it plays a role. Like it sometimes it can cause disorientation. And so in the vehicle, we can sit as a passenger or as a driver. So there are different disorders. We know that the disorder of common disorder as a passenger, if somebody feels dizzy as a passenger, it is motion sickness, and there are variety of symptoms of motion sickness like dizziness or vertigo, nausea, vomiting, headache, drowsiness, fatigue, yawning, and malaise. So differential diagnosis of dizziness in vehicle in general is motion sickness, vestibular migraine, persistent postural phobic dizziness, Meniere's disease, motorist vestibular disorientation syndrome. So amongst these, motion sickness, it can happen as a passenger. It happens only as a passenger. Meniere's disease, many a times I have heard history from the patients that they get an attack. Attack gets triggered while driving or as a passenger after a prolonged travel. So, like it can happen that acute attack of Meniere's can get triggered. And patients with vestibular migraine, triple PD, I have seen patients with visual vertigo. Apart from this pure visual vertigo, patients also can develop, as a driver, they can feel disoriented. And so there was a disorder which there is a disorder which is exclusively as a driver, it manifests with dizziness. Exclusively, it is a task specific dizziness. And the first article on this was published in 1985 by Page et al. Described symptoms of disorientation experienced while driving motor vehicles in a group of patients. So this is the first article on this subject, and it was described as a disorder in which patient experiences disorientation while driving and tries to make postural adjustments to compensate, which has serious implications. Like while driving, if the patient tries to do adjustment, it can create anxiety and it can lead to accidents. Even it can lead to accidents, and it can also occur secondary to other vestibular disorder, as I told, that is vestibular migraine, triple PD, and visual vertigo. So pathogenesis, we have outlined in this particular article, that is orientation and motion in space needs sensory signals for force and motion. Because of the complex and dynamic driving environment, uh, uh, there is in patients with MVDS, this particular entity, there is either inadequate sensory stimuli, sensory signals. They are either inadequate or they are inappropriate. There is an inappropriate interpretation of these stimuli, which leads to the this disorientation and motorist vestibular disorientation syndrome. And triggers for this could be like structural or cellular diseases, anxiety, unknown factors are responsible for the pathogenesis and as a trigger. So this is the complexity of roads in Dubai if you have visited, and there are various you can bends and turns, bridges. It's full of highways, multi-lane highways. And specifically, we have like here I have observed, because of the complex dynamic environment of this driving at specifically at higher speed, that is speed more than 80 kilometers per hour, at bends and turns, multi lanes here, and uh, yeah. So if there are multi-lane highways, then slopes. Whenever there are slopes, the patients feel disoriented while overtaking a big vehicle and looking at other vehicles at signals or in motion. So these are the variety of situations where the patients can feel disoriented or dizzy. Uh, so this is one of the video. I hope it plays one second. It's not playing. Maybe I'll show if the time permits later on. So what happens is during the driving and yeah, yeah. So you can see this Sheikh Zayed Road, and this is a multi-lane highway, and vehicles. There is a differential movement of right and left half of the visual field. If there are variety of things, like for example, if the driver is driving at a speed of more than 80 kilometers per hour, specifically if patients with MVDS can suffer from this particular disorientation, and if there is a big vehicle passing by from the right hand side, then it obliterates the optic flow coming from one side, and the optic flow from the left side is there, and that can lead to a kind of disorientation. And whenever there are bends and turns, that can also lead to disorientation in this group of patients. Uh, Patients feel relatively better when they are driving in a single lane. In a single lane, they are comfortable. But there are some places where some optokinetic like stimuli are there in sometimes in bridges. They can also make some of the drivers confused. Like you can see here in the optic flow, if there is something which is confusing or only on one side, that can lead to disorientation. So MVDS is a lesser known entity amongst clinicians. There is a scarce knowledge about this disorder. Though through this study, we intended to present first 24 patients diagnosed with MVDS. So I have currently around 42 to 44 patients, which were initial 24. We started this study, and we published. So coming to the materials and methods, see the data from these 24 patients who were diagnosed with MVDS, attending the neurotology and vertigo clinic at Astor Garden Specialty Clinic, Dubai, and Medical Trust Hospital, Cochin, from Dr. Preeti and Dr. Nazreen also contributed two cases. From during this study period, we retrospectively reviewed their medical records, their history, video nystagmography findings, and relevant investigation. And in some patients, we could take the dizziness handicap inventory like pre-treatment and post-treatment. Not all the patients. So 18 out of 20 patients were diagnosed with MVDS were males, and 10% were females, with an age group mean age group of 45.5 years. 85% patients diagnosed were involved in driving as a part of their profession. It was their profession, like profession. Because of profession, it demanded daily driving, and five of them by were drivers. They were like, for example, I'm sorry, 25% were drivers by profession. As a profession, they were driving, and 85% of the patients it is involved like driving as a routine part of their profession. Then, for example, coming to driving experience, 14 out of 20 had more than 10 years driving experience, and minimum driving experience was observed was 5 years. So initially, when we start learning the driving, everyone is disoriented while driving because there is a coordination. It is a learned cognitive skill. So we have to coordinate all the centers, and we have to develop the pathways while driving. But that initial disorientation is something different. But as a well-established driver, if somebody is able to drive, and then this specifically this MVDS happens in people who are long-standing drivers. The minimum driving experience was 5 years. Due to unknown mechanisms, they become susceptible to the various triggers in the complex environment of roads. So the duration of illness was up to 10 years. Some patients suffered before diagnosis, and the mean duration was 2.4 years. This 8 days is because of the I started collecting the data of these patients. You tend to diagnose some patients early, like one of the last patients whom we recruited. We could diagnose him early with the 8 days history because he came early. Like many patients, what happens? They consult many variety of doctors, and like they don't know what to do about this particular problem. And it is something similar to mean time to diagnose patients with triple PD. If you see the mean time to diagnose triple PD, according to the various studies, is 4.5 years. And these patients consulted almost 1 to 8 doctors. A number of episodes varied from few episodes to daily suffering. It is not same in every patient. Some people get few episodes sometimes, and some people were suffering on a daily basis. Now, coming to the clinical characteristic we observed in this patient is the most common, like the most important observation, clinically significant observation was 62.5% patients had history of migraine. Like that was something very significant. And the symptoms while driving were variety of symptoms, like vehicle might turn to right side, turn to left side, disorientation while driving, dizziness or vertigo, like imbalance, a sense of imbalance, like they might go to right or left while sitting, blackout, sweating, and palpitation, and cold extremities. Why these four symptoms happen is because these are pre-syncopal symptoms. Because these patients develop tremendous anxiety, and that leads to tachycardia, and that can activate this neurocardiogenic like feature, syncope like feature, and it can lead to blackout. Many patients make their body stiff while driving, and it happens with all of us also. When we are driving, when we are have a challenging situation while driving, we tend to stiff the body. The more we relax while driving, then we can enjoy it and we can avoid that. Why we get problems like body ache after driving is a long drive is because of tightening of muscles in various situations. Neck pain is a very common thing, which because of the tightening of the neck while tightening of the neck muscles. But specifically in this disorder, these symptoms can happen. Which side the patient, which side do you feel the vehicle wearing? In our study, we found that right side, 6 patients, left side, 6 patients, and I don't feel it. There were some patients who didn't feel any particular wearing to any particular side. So, so as I was discussing, I'm not sure whether you are clear. There is a vehicle, big vehicle passing on the this left side. So this is photograph taken from driver's cockpit. Like right side is empty. So the right visual, the optic flow, the optic flow coming from the right half of the visual field, which is going to the left occipital cortex, is intact. Like it's on, but there is obliteration of the visual flow coming from the left half of the visual field, and there is asymmetry between this optic flow. And whenever there is asymmetry, this is something similar to the asymmetry in the vestibular inputs. Like for example, if a person has a vestibular loss on right side, then the vestibular system on the left side tries to push the body head uh, towards the right side. So that leads to nystagmus, that leads to wearing while closing the eyes, and that is a pathophysiologic basis of many signs which are seen in vestibular loss. So something similar also happens in case of vestibular this difference between the optic flow coming from the right half and the left half of visual field. That is the importance of vision in case of balance. Like that is. That's why we include vision in everything, like not only in while we are walking, even while we are in a passive movement as a passenger or a driver, we need intact visual pathways and functioning visual cortex to maintain a stage of normalcy and don't get disoriented. So that induces the right half of the visual field is open and the optic flow is good, and the left is obliterated. That leads to a kind of vection, like the we even in normally whenever a big vehicle is passing, we do feel little abnormal feeling in stomach, and we do tighten our muscles. when a big vehicle is passing by. That is a physiological sensation because of that asymmetry. Something similar physiological sensation if we rotate continuously merry-go-round, then that also leads to stimulation of one-sided vestibular system and other-sided inhibition, and that leads to a kind of vertigo followed by that. So something similar does happen in normally, but this phenomenon gets exaggerated when in patients with this motorist vestibular disorientation. So these are the neurological findings which were seen back in 1985. Really, our forefathers, the way they used to observe every patient and the way they have, despite of lack of equipments and special gadgets, here you can see that they reported 6 cases and the type of disorientation they mentioned, like, and the associated symptoms, predisposing factor, almost some similar kind of spectrum, and the duration of illness. The duration of illness also was very ranging from 2 years to 15 years. So the triggers, as I mentioned earlier, a higher speed, bends and turns, multi-lanes. So individually, the patient had multiple triggers in one patient. One patient might be having 2, 3 triggers. So upward slope, some patient had downward slope problem, looking down from bridges, overtaking, looking at other vehicles, closed tunnels, some patient get problems. And changes done in the routine where stopped or reduced the frequency of driving, avoid long journeys. These are the real responses from my patients, like our from our series. Avoidance of driving on bridges, reduced overtaking, reducing the speed far earlier before reaching the signal, driving in low speed, driving in slower lanes, taking frequent breaks in the journey, usage of single lane roads, keeping water or juice ready during the journey, especially those who feel pre-syncopal symptoms while driving. And there is one peculiar thing which is mentioned in Adolfo Bronstein book about motorist vestibular. These patients can also go to check the vehicle. Why I didn't find, maybe I was thinking about that, and I found that yearly we have to check the vehicle here in Dubai. Like, there is a vehicle inspection and vehicle license. We have to renew every yearly, and it undergoes a thorough checkup. And if there are any deficiencies in the vehicle, it gets checked every yearly. So maybe that is the reason why, maybe in my study, we couldn't find any patient. We didn't find any patient who undergone of course, but patient might think that it might be a problem with the vehicle initially, but because of the somatic symptoms, they do get physical symptoms. So that's why they many a times they can recognize that there is some problem happening while driving at higher speeds. So, what are apart from these symptoms, like while driving, half of the patient did have motion sickness. As a passenger, also, half of the patient had, and we tried to explain this in the discussion that many of the patients had migraine, 62%. So that could be the reason that these patients were having motion sickness as a associated symptom. Then comorbidities, in terms of structural cellular disorders, 60%, as I told, had history of migraine, 50% had motion sickness, 2 patients had vascular loops on MRI. I don't know the significance of that, but they didn't have paroxysmia like symptoms, but 2 had vascular loop, asymptomatic vascular loops. One had old history of vestibular neuritis in the past, 5 years ago. One had epilepsy, one had early Parkinson's disease. So this is something similar to this spectrum is something similar to triple PD. Like, in patients with triple PD also there are comorbidities. There can be some vestibular disorder or medical illness which can trigger the functional disorder. So again, MVDS is a type of functional neurovestibular disorder, something like triple PD. 34% patients, almost 35%, had anxiety. 16.7% had depression. Something again similar to functional vestibular disorders like triple PD. That triple PD also has comorbidity. Comorbid patients have comorbid anxiety and depression, but that is not the exclusive thing. That is very important. Functional disorders are separate from psychiatric and separate from structural cellular disorder. It is something in between the structural and cellular, structural or cellular, and the psychiatric disorder. It is a separate entity. It is not that all patients with functional disorder are not having anxiety or depression. Of course, the comorbidity is more as compared to structural or cellular, but not all patients have anxiety and depression. They can develop secondary anxiety and depression later on because of their suffering. At present, so MVDS is considered to be an extension of a blanket term, that is triple PD, which is a complex functional neurovascular vestibular disorder thought to arise from mismatch between anticipated and actual movements that occur transiently during the course of normal voluntary motion, efferent-afferent mismatch. So it is a functional neurovestibular disorder. So through this article, we tried to divide the two types, that is primary motorist vestibular disorientation and secondary motorist vestibular disorientation. So primary we can call when the symptoms are exclusively experienced while driving and the patients have no other vestibular disorder to explain the symptoms. So the patients get exclusively symptoms while driving. Apart from driving, they don't have symptoms and they don't have any other vestibular disorder to explain the symptom. They might have some disorder in the past, but that cannot explain the current symptoms. So, and the secondary MVD we have tried to classify as an patient has an underlying vestibular disorder explaining the symptoms, and symptoms are not exclusive to driving because these patients suppose get the symptoms apart from driving also. For example, a patient with vestibular migraine, patient having spontaneous vertigo or dizziness or head motion induced dizziness, or the patient has along with the apart from driving, the patient has while driving some visual symptoms, especially in the evening when there are lights, that it triggers their visual vertigo. That is secondary MVD. Secondary MVD where the patient has some primary disorder and which is causing the symptoms while driving. The same thing can happen in patients with triple PD also and other vestibular disorders. So if it is primary, what is meant by primary is patient symptoms are only while driving, not apart from driving. And second is there is no other vestibular disorder to explain the symptoms. So this is the proposed classification. And a proposed diagnostic criteria is two or more symptoms of dizziness while driving on most days, such as vehicle might turn to one side, disorientation, presyncopal symptoms, postural adjustment. One patient I distinctly remember, during my early days of practice, he developed presyncopal symptoms while driving. And to be honest, I investigated for neurocardiogeny or types of syncope, there are variety of types of syncope. So it's very important that we should, apart from that investigation, patients should be asked whether they have symptoms of veering of vehicle to right and left side or other symptoms which are apart from presyncopal symptoms, and that is triggering the secondary presyncopal symptoms. Then symptoms are present exclusively while driving and aggravate during the following situations, like I have mentioned them, all of them earlier. And the disorder begins insidiously. I have seen that this disorder slowly begins and insidiously begins without any identifiable. All these patients, there is no identifiable trigger. If there is identifiable trigger, then it becomes a secondary MVD. Like suppose a patient with vestibular neuritis or a patient with an attack of Meniere's. Obviously, they are going to have difficulty while driving vehicle. So that is something not seen in primary. So this is a diagnostic criteria for primary MVD. Then symptoms cause significant distress and or functional impairment while driving. Symptoms are not better accounted to any other disease or disorder. So, in this postural adjustment, the patient can cause stiffness of the body, holding the steering wheel tightly. This is something similar to patients with triple PD. While walking or standing, patients with triple PD tighten their muscles, tighten their neck muscles while walking or standing. And that same thing happens while driving in these patients. Then second thing is patients devoid of de novo symptoms of visual vertigo or other vestibular disorders like vestibular migraine or triple PD. Why these patients are not cannot be called as vestibular migraine? Because they are developing many of them had associated migraine, but why we can't call them as vestibular migraine? Because the symptoms are happening exclusively while driving. Apart from driving, they were not having any vestibular symptoms even though they had migraine. So this is how it is. And as days pass, you keep learning. And now these patients are, when they are coming for follow-up, some of them are developing vestibular migraine also. Like some of the patients are developing symptoms apart from driving in the patients with history of migraine. So we keep learning, and I'm going to continue the follow-up of these patients and come up with revised, we keep learning. That is something which happens when we write article. So these things are not going to remain same. As we evolve, as we collaborate, the knowledge about this disorder is going to change. Now coming to the VOG abnormalities, which were seen in the first article, like spontaneous nystagmus was seen in some of the patient, induced nystagmus was seen, pursuit abnormalities were seen in some of the patient, and optokinetic nystagmus. Specifically, we observed, like we tried to see whether there are optokinetic abnormalities in patient. For example, if some patient is saying that vehicle is veering to the right side, we tried to correlate whether the optokinetic movement, like when the from right to left stimulus versus left to right stimulus, are there any asymmetries? We did find asymmetry in these patients, but they were not statistically significant. I took help from Srinivas sir for this, and we tried to see whether, but of course, the gains were more on one side as compared to the other side. But toward the side of wearing, the gain was more, but it didn't reach that statistical significance in our study. So these were the findings which were seen, like horizontal saccades, vertical saccades. Some patients were having some, maybe an impression of their old disorder which they had in the past. So that these are the, and we recorded the ocular movements using the video nystagmography goggles, that is Balance Eye, binocular VNG system by Cyclops MedTech. So the VNG findings were recorded in these patients, and we tried to see if there is anything happening significantly in this group of patients. As I told, there was no statistically significant asymmetry, and we could not even correlate in upward and downward slope patients. Also, we tried to correlate whether the optokinetic nystagmus in upward stimulus versus downward moving stimulus, are there any asymmetry, didn't reach statistical significance. Now, the principles of treatment, as mentioned in the book by Professor Adolfo Bronstein, is if a patient has car tilting illusion, like car is veering to the right and left side, and there is a previous vestibular disease and there are no panic attacks, then these patients are good candidates for vestibular rehabilitation. And if there is no car tilt illusion, no vestibular disease in the past, and the patient has predominant panic attacks, then these patients will benefit by SSRI, anxiolytics, and CBT. This is how it is categorized in the and this in our study also we found that almost 34% patients had anxiety. So these patients will primarily improve by SSRIs, anxiety, anxiolytics, and cognitive behavioral therapy. And those patients with wearing of vehicles, they will need vestibular rehabilitation. They have to get fully compensated for their vestibular loss which happened in the past. No, in my study, predominantly, because of lack of resources, you can say, predominantly, I treated them with the drugs. Because it is a study which was conducted almost 2.5 years, I saw 24 patients, around 1.5 or 2 years ago. Definitely, yeah, we concluded this 24 patients, and after that, again, I saw around 18 patients. So day by day, then as the knowledge is evolving, we are introducing the vestibular rehabilitation techniques, and I'm referring the patients to the psychiatrist. But predominantly, I treated with medications. These were the medications used, and the VRT. In terms of VRT, these patients will get benefited by car simulation games. And it should be interactive game, both in terms of they are sitting and they are provided a visual screen, and they are feeling like they are driving a vehicle. That kind of games, it will benefit this group of patients, and we can simulate they are going at high speed, bends and turns. Specific VR protocols can be developed for this group of patients, and it will help them to rehabilitate themselves in a stable environment, like directly taking them to driving. In this environment, virtual environment, they can be rehabilitated. And cognitive behavioral therapy, especially those patients who have psychiatric comorbidity. So this is the data of 20 patients, where some of the patients specifically I would like to mention is one of the patient received amitriptyline, and the dizziness handicap inventory dropped from 52 to 4, with only amitriptyline, even without vestibular rehabilitation or cognitive behavioral therapy. That is the importance of drugs. We cannot underestimate any one of these therapies. Like, it's equally important, like all the three parts of the treatment. Even in triple PD, drugs are important. Cognitive behavioral therapy is important if they have psychiatric comorbidity, and even and the vestibular rehabilitation is also important. In this particular patient, I started with amitriptyline. There was no improvement. Then I added bisoprolol magnesium. There was 30 to 40% improvement. But I changed to this venlafaxine, and the patient had 80% improvement. So what happens, we keep learning. It's not that the regime is same for every patient. Every patient might respond to different group of drugs. That's why you can see the spectrum of medications I have used in this order are totally in this patient improved 40% only on amitriptyline. Then I added bisoprolol and magnesium, and patient had near complete improvement. So we different group of patients responded differently to drugs. And there was another patient who had vascular loop on MRI, which responded to gabapentin. Like, the patient didn't respond to amitriptyline. Then patient had side effects with aceclidine. Because of the vascular loop, I thought of giving carbamazepine. There was no improvement. But when I added gabapentin, the patient had 70 to 80% improvement. Of course, gabapentin does help for anxiety also, and that is also true for pregabalin. Like pregabalin, some of my patients improved with pregabalin also. So, for example, no improvement with carbamazepine and pregabalin, 50% improvement with amitriptyline and magnesium, and 80% to 90% improvement on gabapentin in this particular patient. So, different patients had different responses. So, the natural history, if I want to classify this patient, it is some patients improved completely. Like, one of my friend who is a surgeon, he called me one day that he's suffering from attacks of disorientation while driving, and he had two episodes in last for example, he called me 2 years ago, and he was having. So he had for transiently, I told him to start amitriptyline, but later on I'm in touch with him, and I asked him recently. Without taking amitriptyline, he had improvement. So some patients do improve like completely with or even without treatment. Some patients took transiently for 1 or 2 months amitriptyline, and they improved. Later on, they didn't have continuous symptoms. Some patients improve with medication. I'm telling more than 50% improvement can be seen, and some patients don't improve despite of all the modalities of treatment, like suffering on a daily basis despite the treatment. Like some of my patients even lost to follow up. Maybe they are not improving with their variety of drugs given. So there are two patients who they are not following. Maybe it can happen that sometimes the drugs may not help and the cognitive behavior. If the patient undergoes every aspect of the treatment, then maybe the patients can improve. So comorbidities in patients with comorbid migraine, I have started them first on migraine prophylactic medication and they responded. Patients with vascular loop, I started. This is what I have learned. Like gabapentin, pregabalin might help in this group of patient. This cannot be called vestibular paroxysmia, honestly, but they had vascular loop asymptomatic. I'm sorry to mention it as paroxysmia. Then old history of vestibular neuritis, only one patient had. This type of patient will improve by vestibular rehabilitation by giving them compensating their illness. Early Parkinson's disease patient responded to Syndopa. And similar patient I saw during my residency also, my teacher, professor, he told me that he saw one patient in his clinic that patient is feeling wearing of vehicle to one side. And when he checked, a patient had actually right hemi Parkinson's and he was feeling the wearing of vehicle on the right side. This is because of the differential tone of the muscles. So the right sided muscles were more rigid as compared to the left side. So in practice, you can get variety of patterns of the patients. One patient had epilepsy who responded to carbamazepine. So, and limitations of the study was this was a two-center study. There were variation in the history taking and between our two centers. The treatment was not uniform in all the patients. That is what I'm planning in the next whatever patients I'm receiving. I'm planning to keep the treatment uniform so that every patient receives according to the approach given by Professor Adolfo Bronstein. And follow-up outcomes were not recorded in all the patients. It is a retrospective studies. There, the gaps in the data could not be addressed by following up with the patients, and therefore the plan is prospective cross-sectional study. I request if any of you have any patients, we can collaborate and we can go for a larger study population and we can see we can go for a prospective study. So conclusion is MVDS is a distinct clinical entity, needs diagnostic consideration and treatment. Mean time to diagnose this condition can be reduced by awareness about this. Most treatment respond well to the treatment of comorbid condition, especially migraine if they have. Of course, not only drugs, other things are important like treatment of their anxiety and treatment of the vestibular compensation is also important if they have vestibular loss. So these are my references, and I thank you I thank so much to these contributors of my article, like Dr. Hanan Ashraf, who helped me in the conceptualizing. I thank Dr. Preeti and Dr. Nazreen, who were really played instrumental role to design the study, and writing the original draft preparation was done by Dr. Nazreen and Dr. Preeti. I would like to thank Divya for the biostatistical help and Leah for helping me to curate the data. Data analysis was done by Dr. Shweta and again Dr. Divya. Handy resources were Anantu and Mohammad Shauka. I'm really thankful to both of them. They were helpful, whenever help is needed for this article. And I thank to Srinivas sir for supervising and giving us inputs about the VNG findings, to decide the symmetry. And he actually calculated the gains and he gave us formula to decide the symmetry whether it is significant or not. So I thank all the my co-authors for contributing to this article. And I'm especially thankful to Dr. Haripriya, who is currently here, like in Dubai, specifically for research work. She has taken a leave, a sabbatical leave for research for 1 month. She is enthusiastic ENT surgeon from Thrissur, Kerala. She's currently working in Chennai. She has worked for some time in CMC Vellore Medical Trust Hospital from Kochi, and Bhopal also. She has worked in skull-based surgery. I'm really thankful to her. We are planning a series of articles and a lot of projects we are working on in this 1 month when she's here. And apart, any one of you, if you are interested in research, these are my contact details. This is my email and phone number. Like if you are interested in research, please collaborate. So it's all about collaboration. We can collaborate about various cases and we can come up with articles. If anything interesting you find, or if you are interested in research, please let me know. I will see whether how we can collaborate and we can work on different articles. So this is with that I thank all of you. This is my poster which I presented in Barani Society meeting last year in Spain, Madrid, and I'm with Professor Adolfo Bronstein, who was very keen in looking at all the findings, and he was also of the opinion that patients improve with migraine medications and they do have a comorbid migraine, like past history of migraine. So with that note, I thank all of you for being with me on Sunday evening. I'm like, if there are any questions, we can open up the forum for the questions. Yeah, over to you, Dr. Sriharsha.
Thank you, sir. Wonderful presentation as usual. So I have few questions from my side. Have you tried any vestibular rehab, sir, for these patients, like any optokinetic stimulus? Does it work?
Yes, yes. For some of the patients, I have tried vestibular rehab in the form of. I'm really sorry. Just give me a minute because I will connect to power. I think it is getting like it's very low. Just give me a minute.
Meanwhile, if anybody in the audience would like to uh, ask questions, you can unmute and interact. So the unmute option is enabled now. Anybody who wish to clear their questions, queries can unmute.
Yeah. So coming back to your question, as I told, because this study participants were earlier, in the early days of like 2.5 years ago. So predominantly I have treated honestly with the drugs. And from last 2 years now, we have virtual vestibular rehabilitation goggles, VVRT goggles from Cyclops, and there is a protocol like where the patient is sitting in the car and moving around. So that we are I'm giving to like that I have included, and optokinetic training also we are giving to this group of patients, and patients who have associated psychiatric comorbidity. As I told, I'm taking the help from our psychiatrist.
Sir, and there's a separate entity called visual vertigo. No? So how different is this? I mean, do these conditions coexist in the patients?
Yes, that's what. So that's why that's what I was observing in my during my practice whenever I was trying to enroll patient. Some of the patients have actually visual vertigo, and they can with patients with visual vertigo. It's not necessary that they get symptoms while driving. They can get symptoms while driving also. They can get symptoms otherwise also whenever they go to watch a movie, when there are moving stimuli. They can get symptoms anywhere. It's not related to the driving. So that's why I included patients who exclusively while driving, not getting otherwise. So Patients with visual vertigo, if they get symptoms while driving, then we can qualify it as a secondary MVD. That's what it is not there in literature, but in this article, patients with vestibular migraine or visual vertigo or triple PD, if they are developing symptoms, I have tried to call them as, and I didn't include in this study. Maybe in the next study, I will include both the group of patients like secondary and primary. So that is, yeah, that is a very good question.
So, any more questions from the audience?
Hi, sir. Good evening. It was a fantastic lecture.
Yeah.
Just wanted some. I actually missed the last part of the lecture where you were talking about probably about the treatment. So can you again just highlight, because I missed it because of a call. So
Okay. Okay.
you use amitriptyline very often, as per our last discussion over the group. So sir, any other successes apart from amitriptyline, or maybe with the SNRIs or SSRIs apart from the TCAs? So if you can
Yeah.
just add on that, yeah.
Yes. So, see, there are three aspects of the treatment. One is drugs, like medication. Second aspect is cognitive behavioral therapy, and third is vestibular rehabilitation therapy. Now, coming to the medications, all the patients I have tried medication. All the patients received medication, and in terms of medicines, what I found, the medication will work if they have look at the comorbidities of the patient. Like if the patient has comorbid migraine, then the patients are likely to respond to migraine prophylactic medications like amitriptyline, beta blockers, and magnesium. Even the SNRIs also help in migraine. So that is true, and amitriptyline is one of the medication I have found which is helpful in most of the patient. But of course, there were patients who didn't respond to that, and SNRIs like venlafaxine and disvenlafaxine were helpful in this group of patients. There were two patients who had asymptomatic vascular loop where gabapentin was helpful. So based on the comorbidity, we can decide the medication. Refer the patient to psychiatrist if they have psychiatric comorbidities, like check their GAD-7, Generalized Anxiety Disorder Scale, check their PHQ-9, like Patient Health Questionnaire 9 for depression. And it's very important, like the practice becomes complete when we start analyzing their psychiatric comorbidity. Really, vestibular practice becomes very complete when we start analyzing them, that and giving importance to the mind, because we treat the body like with very good drugs, the patients may not improve, but if unless we take care of their psychiatric aspect, and it is our responsibility to convince the patient to consult psychiatrist, because many times these patients are reluctant to consult psychiatrist, why it is needed. I usually how I tell them is, it's like your treatment is like tires of the car. There are four tires, and suppose you say like, okay doctor, I will drive with only three tires, I don't need one tire. Many a times patients say that, no, I will not consult psychiatrist. So unless you try to tell them that that will make your treatment comprehensive, unless you do that, even the same thing can be used to convince the patient to for the vestibular rehabilitation. Some patients don't get convinced. It's very important to treat them comprehensively.
No, no. Very true, sir. We also believe of the same principle that there has to be multidisciplinary approach. Sometimes, in some cases of vertigo, and that makes a lot of difference. In this case, sir, it was a fantastic lecture yet again, and congratulations.
Thank you so much.
There's one question in the chat section, sir.
Yeah.
How can you differentiate MVDS from MDDS?
Yeah. So MVDS is nothing but driving related dizziness. When the person is driving, the patient feels disoriented. That is MVDS. MDDS is mild day department syndrome, in which a patient goes for some ride. It can be a cruise ride, it can be a flight journey, it can be anything, any type of journey. not during the journey. Once the person returns from the journey, if while at journey, if the patient develops symptom, that is nothing but motion sickness. Or suppose the patient develops the same problem while ride, seasickness, like suppose cruise, like when the patient goes for a cruise, then it is a seasickness. But after returning from the cruise travel or any travel, then the patient after a certain latency develops the symptoms which are present. If they are present less than 1 month, it is called as transient MDDS. If they are persistent, like more than 1 month, it is called as persistent MDDS. So in last 3-4 months, after listening to Viviana Musi, who has done a lot of work. She works in Dubai, and because of her lecture in IFOS, I could diagnose 3 patients in last 2-3 months, and it's very important to ask them whether they went for a boat ride or any type of any activity like that. And some patients even tell that they went on an aeroplane and they came after the flight and they felt dizzy for some time, 1 day, 2 day, 3 day. That kind of dizziness is actually also transient MTDS. Like, so that is the difference between motorist vestibular disorientation and mal day debarkment. In mal day debarkment, there is a altered physiology. Like what happens is normally our vestibular system is tuned to the stable earth, like on the earth. But if they go to the journey, like some movement journey, what happens is it gets like a new normal. It is new normal for the vestibular system, and it compensates for that type of journey. But when they come back, it should delete that memory. When they come to the again to the earth, the stable surface, it should delete that experience. But unfortunately, that deletion doesn't happen, and that deletion doesn't happen, and it leads to decompensation, and they still keep on feeling that type of sensation. And again, the optokinetic rehabilitation will help in this group of patients.
So I think that's all we have in the queries. So once again, I thank all the audience who have attended, and we're really happy to meet you all after a long time. And hopefully, we'll be continuing this practice of doing Vertigo talks every monthly, and we'll see you again in the next month. Thank you. Good night, everyone. Thank you, sir.
Yeah, thank you so much.